All right, very good. Well, we are going to talk about caregiving today, but first, I thought I would talk a little bit about telehealth. And this is important because, like, our educational programming right now coming across over the internet, really, technologic advances are not new. We've had them for quite some time. And as a matter of fact, years ago, 2005, when I first came to the University of Kentucky, just a few months into my practice here, I was asked to visit with a young lady from Olive Hill, Kentucky, who absolutely refused to admit that she had a memory problem, despite the family trying to get her to do so. And she absolutely refused to come to Lexington. And so, really, we were contacted to say, is there any way that you might be able to do this over the internet with video conferencing technology? And hence, I did my first telehealth or telemedicine evaluation and interview. And I was struck by how well it worked. And that really got me hooked. Over the years, I have the most active and long-standing telemedicine clinic at the University of Kentucky. And as such, I was appointed the medical director for Kentucky Telehealth, which is the statewide telehealth facility. So we'll talk a little bit about that. Then we'll move into some of the issues with caregiving. But telehealth, really we can think about it as, it's this technologically advanced thing that I might not be able to do. But really, its purpose is to get the right care to the right people at the right time in the right place. And so that's the overarching theme. And we can think about that right now as we're in the midst of the coronavirus pandemic. We all need care, and yet it's prohibitive for some of us to get to the doctor. When we talk about the right people, we're talking about the population that is aging over the age of 65. Those are the folks that may be at highest risk for contracting COVID or having negative consequences from it. And so using this technology as a way to keep folks safe. And so we're clearly in the right time where this is needed. And it's really been amazing to me to watch for something that I've been doing for 15 years and think of as really just a part of my daily activities, that 99% of the physicians at the University of Kentucky 3 months ago had never done a telemedicine visit. They did not know what telemedicine was. They wanted to steer clear of it. As a matter of fact, we had a faculty engagement program at the University of Kentucky back in early February, before COVID really hit the fan or anybody was thinking about this. And it was to educate faculty on how they could provide services through telemedicine. And I hate to say it, I devoted an hour of my time. We only had 4 people show up. So 4 out of the 1,000+ doctors at UK, 4 of them thought that this was an important thing that they should hone in on. And today, 3 months later, virtually 99% of the physicians at UK have now done telemedicine and wish that they had attended that initial evaluation or that initial education program. So one would say, why telemedicine? Why Kentucky? Well, I always say Kentucky's a big state. And we can think of many of my patients coming, I don't know why my slides are advancing on me, from Pikeville. That is, to almost 3 hours driving just in one direction. So 6 hours in the car potentially to visit with me for 30 minutes. On the other side, Paducah, is even worse. About 4 hours, 4.5 hours. That's 9 hours round trip to come and see me. And there are not memory experts in those areas of the state. And so folks do travel that far. And one can think about that, as I always say, 6 to 8 hours round trip for a person with dementia. Oh my goodness, that is problematic. One can imagine. It's problematic for the patient who has dementia, that is very disruptive to routine, and it places an added stress on our caregivers. So, that was one of the main reasons why I got involved with this. Of course, we're using it nowadays, even for people that are right down the street in Lexington. One of the reasons why we haven't had this opportunity to use this previously is that telemedicine prior to COVID was only covered for rural and underserved areas of the state, meaning as much as I would have liked to have used it to reach out to some of my folks where even the travel 5 miles across town, getting somebody out of the house into the car was problematic. We simply weren't able to do it. But now COVID has changed all that, and this has really become part of our life. So if any of you have not yet had a telemedicine visit with your primary care doctor, this is something that is occurring regularly for those that need non-emergency care. You can't get an emergency room visit over this, but for routine care, telemedicine is the wave, and it is anticipated that even when the country gets a handle on COVID, even when we have a vaccine, this is going to become much more commonplace in terms of our interactions with doctors. So now I always think of these things, and so I was intrigued by my initial clinical visit, thinking, wow, I can really help people clinically. But it also raised a number of questions in my head. Is this as good as an in-person clinic evaluation? I didn't really know. Does this give me the opportunity to help people in underserved areas, perhaps in Appalachian Kentucky? There are different risk factors for dementia. Risks we know that there are for lung disease and for heart disease and for other diseases. That was a real question. And we also understand, as we're doing today, that we can use the telemedicine technology to advance education. So in academia, that is in a university setting, I'm just a doctor in a private practice office, but we think about all three of these things, and we call that anybody that does all three of these is considered a triple threat. So that is a term that is frequently used to describe many of my activities. I like to think of myself as a triple bonus, a triple present. I don't know about threat. I don't know who I'm threatening out there by trying to help people with dementia, but nonetheless, that is the common phrase. So after that initial visit, I decided to set up a telemedicine memory clinic. And our goal was really to provide high-level care for memory and thinking problems in areas where there weren't memory specialists. And the goal was not to take patients out of their community, but instead to augment the care of the primary care physicians in those areas and really help. And I still think back, I think it was 2007. I was at a meeting of the chief executive officers for the Appalachian Regional Healthcare Hospital Coalition. So, as everybody knows, it's about 20 hospitals, maybe more, that are scattered throughout eastern Kentucky. And I was talking about opening this program and how we could help them. One person set up in particular, and I don't remember his name. He was from the Whitesburg ARH, and he said, well, this is all fine and dandy, but there is no dementia in my community. Now, I knew that that was not true because I had seen many folks that I had personally diagnosed from Whitesburg who had driven 2+ hours to come up and visit with me in Lexington. He was not aware. And it's clear if people in Whitesburg were not even aware that dementia was a problem, how could you possibly hope to have the resources to enable you to tackle that? So I went back to the clinic and I began to look at my live in-person examinations. And this is just a colorful graph that shows us kind of a breakdown. What I did was I videotaped several of my, probably a couple dozen of my in-person in-clinic examinations, people who I had asked to drive 4 or 5 hours to come and see me. And what I found was I spent about 50% of the time taking a history. Tell me what's going on. And then at the end, talking about, well, this is what I think the diagnosis is. Here's what we need to do from treatment. There is a portion in red here, brick colored, that was devoted to testing memory and thinking. A small portion of green is what I call the observed physical exam. That is, I'm watching somebody move their arms, move their legs. And it turned out that really only about 5% of the time in the evaluation was actually spent where I was touching the patient, checking their reflexes with my rubber hammer, checking their strength, seeing if they could feel me touch them. And so I thought, wow, 95% of the exam, I actually do not have to touch the patient. And this is great because we don't have Wonka vision, right? From Willy Wonka and the Chocolate Factory. I can't jump through the TV screen and actually be there on the other end, nor would I want to shrink like little Mike TV. So I thought about this and I thought, is there more information we could get from that physical exam, from just watching somebody over the video? And very carefully, I looked at this and I found that the answer was yes. And so I did a second study that looked at, this is what's called the UPDRS, the Unified Parkinson's Disease Rating Scale. Now, everybody knows Parkinson's disease is a physical condition, and everybody thinks you really need to examine the patient for their physical abilities. And what I looked at was, well, if I use the UPDRS to determine whether or not somebody has Parkinson's or not, can I figure it out using the UPDRS over the video? And the reason why I did that is that when you take the training to become certified in diagnosing Parkinson's disease with the UPDRS and staging it, you're trained on a video. And I thought, well, if they can train us on a video, why can't we conduct this? And the results were just astronomical in terms of how these related. This is what we call a kappa score. It's how well it agrees. So that really consoled me that, yes, indeed, I can confidently examine somebody, not just from a memory and thinking perspective, but I can examine them physically for signs of Parkinson's disease or potentially stroke over a video camera and the internet. So I developed the telemedicine appointment for memory and thinking, and this takes about 40 to 60 minutes. I review with many folks, and I've examined thousands now using this method, the history of their current symptoms. We review their past medical history, their medications, allergies, family history, all the things you do in a normal doctor office visit. And then I developed a very short 15 to 20 minute memory and thinking evaluation, which actually, even though it's short, 15 to 20 minutes, contains some of the most sensitive measures for detecting especially early memory impairments. So somebody where, boy, they still look normal at times, but sometimes they might have a memory problem. Are they heading down the path towards Alzheimer's or something like that? And these are the tests that I embedded in this. And then a physical examination with some components and a discussion of diagnosis and treatment. So this is what it looks like. So you see the back of my head there in my white jacket in the telemedicine suite. And I've got a camera on me. You can see me in the lower right-hand corner of the screen. And there's my patient. And at times I can ask, I'd like to see your face up close. And the patient could do that. And here I'm telling her to look up and to the right so that I can see how her eye movements work. This is, just incredibly useful. I can ask them to pull the camera back and walk for me. So I can see how your walking is. If you're having trouble with your balance, if you're dragging a leg, or if you're shuffling like you have Parkinson's disease, that's incredibly helpful. I can have them do tasks like draw a clock and show me as you draw the clock. This is an awesome clock. She's only halfway through with it. Every now and then we do see a patient that just stops there. And we know that that's a problem, but for her, she was perfectly fine. That's Jessie, by the way. It's not an actual patient. Jessie used to be our receptionist at the Sanders Brown Center on Aging, and I asked her to stand in for this, and she was just delightful. Other tests like Connect the Dots, those of you that are research participants know that you've played this game with us before. It is a very sophisticated, believe it or not, very sophisticated memory and thinking test that is able to pick up on whether or not folks have memory and thinking problems. So one of the questions that I talked about previously is, well, will this work? And so we set up an experiment where we had folks that had either been seen already over telemedicine out in rural areas, and we asked them, would you drive to Lexington so we can repeat the examination with a different doctor and a different team to see if telemedicine tells us the same thing as a live in-person evaluation? The other group of folks were from the greater Lexington area, and they had already been seen in person. And what we did was we brought them into the telemedicine facility, and we put them in one room, and I sat in the other room. And we could have been, they could have been in China, and I could have been in Portugal, for crying out loud, if we had international flights right now. Or I could be in Lexington, they could be in Pikeville or Paducah, and we held telemedicine assessments to compare the two. And so there's lots of numbers on this slide, but basically what this shows is that for every single memory and thinking test was as good over telemedicine as it was in person. And this gave us a great degree of confidence that not only can the physical exam work, but the memory and thinking testing works. And that gave us the ability to move on and to really look at, is there any difference? Are folks that live in Appalachian or Western Kentucky in very rural areas, are they different than are folks in the greater Lexington, Fayette County region that come down with memory thinking problems? And it actually turns out that they are. And so this is really amazing. What we find is 2 to 4 years, maybe even more earlier, the folks in the rural areas were coming down with memory and thinking problems. In some instances, a decade or more. We also see the education difference in rural areas. People tend to be less educated than our Fayette County individuals, and no difference for genders overall. We've also looked at several of the risk factors for dementia, modifiable risk factors, and we found that high blood pressure was higher in the rural Appalachian folks examined by telemedicine. High cholesterol was higher. Diabetes was not. Alcohol use was. Quite interesting, what we found with smoking was for our dementia patients in rural areas, they actually smoked less than our dementia patients in Lexington. I don't know why that is. And something we all know, depression is a big problem for many of us as we age, but it is a much bigger problem in rural underserved areas. 70 to 80% of folks in those rural areas with memory problems or memory complaints having difficulty with depression. So we knew that the clinic would work. And again, it's been a godsend for thousands of folks over the last 15 years, and a godsend now that we're in the middle of COVID, that we're very skilled and we've already worked the bugs out of this. And if you or a loved one have memory and thinking problems, we're now offering, if you don't want to come to clinic, you can telemedicine us and we can Zoom right in. But we also thought that we should have some educational programming as well. So we've covered, remember that triple threat, we've covered clinical care, we've done some of the research, and we've received several $100,000 for that over the years. But what about education? And so we started in 2005 a program. We have lots of programs here in Lexington to educate folks, and in Louisville and in Cincinnati, but not so many programs, none at all out in Hazard or Paducah. And so we thought we should build an educational program. And so we did this in 2005. It has no funding. We've continued this over the last 15 years, and this is still a very active program, an educational series for those that live in remote areas, much like what we're doing currently in the education series today, except for the education series today is open even for those folks. There may be somebody online that, is just a block or two away from me. I don't think anybody on my street is on the call likely, although there could be one or two. I don't know. So using that methodology really helped us when COVID kicked in to get this educational program up and running in a hurry. Why? Because we had 15 years experience with exactly how to do this, and that's wonderful. We've been able to help expand support groups, answer many of the questions that folks have, provide community resources through the technology that we're using to gather together today. So this is the Kentucky Telehealth Network. You guys can see that it spans the entire state. Here we are in Lexington. There's my Pikeville to Paducah, but many other sites across the state are involved, and many more. I don't even have the stars on this for all of them. I think this is an older presentation, but clearly the ability to provide care, to understand dementia in your community and memory loss, the ability to reach out with educational and support programming, incredibly important. And so this is a slide that Rob Sprang, who's the top director of Kentucky Telecare, put together, and he said, what telehealth will look like in the future. Well, I'll be darned. This is not the future. This is what telehealth looks like today. And maybe some of you out there are not calling in on computers. Maybe you're calling in on your smartphone, and that is a way to see you. So I'm going to change gears here a little bit. I'm going to talk a little bit about caregiving. And, one of the major burdens that we have out there with caregiving is something called BPSD, Behavioral and Psychiatric Symptoms in Dementia. And this is a slide where at the bottom of the screen, here where I'm scrolling my arrows, is a time before and after the diagnosis, with the red bar being the time when a diagnosis of dementia was made. And on the y-axis, moving up and down, is the frequency, the percent of patients. So up here, 100% of patients. Down here, no patients have these symptoms. And we can see several different things. We can see that 3 years before you're even diagnosed, you're beginning to socially withdraw. Well, that may be a good thing right now with COVID, but within 2 years before the diagnosis, 50% of people come down with a depression that they never had before. A year before the diagnosis, not quite a year, we see disruption, paranoia, anxiety, disruption in sleep cycles. And within 1 year of the diagnosis, look at that, 80% of our loved ones with a memory problem can start to become agitated, even aggressive within 2 years, with hallucinations and sometimes inappropriate behaviors. So these symptoms are important. And I will say right now, with COVID, with everybody sequestered, social distancing in their home, uh, there's been a disruption to all of our schedules. And when we're in tight proximity, and I know this from interacting with my kids, we have a tendency to get a little testy with one another. We've seen each other too much overall. We know that these behavioral and psychiatric symptoms have always been a problem. They're a major problem. They're strongly associated with caregiving issues, strongly associated with undermining the ability for you to provide care. And they're common. So we can look at those symptoms ranging between 40 to 80% for anxiety, agitation, hallucinations, inappropriate behaviors. So we have to go back, if we are, in our home with nobody around but our loved one who has memory and thinking problems, we have to start thinking, they're starting to have more trouble. Why might that be? Well, sometimes it is an expression of needs in the environment. So one can think, if our loved one is agitated and acting up, are they thirsty? Have I seen them drink today? Are they hungry? Have I seen them eat? Are they in pain? They didn't take their arthritis medicine this morning or the like, because the person with dementia, the person with memory and thinking problems may not understand that that's why they're agitated. They may not be able to express that to us. We sometimes see agitated behaviors or other symptoms come up because of distress, feelings of abandonment. Where's the rest of the world? Here I am trapped in my home. Oh my God, what's happening? I'm watching the news and, it's a catastrophe out there. And so very, very important for us to think about those things. So when we are having problems, what we want to do is think about it in a logical way. So one of the things that we do is we kind of take a history and say, well, when the behaviors start, how's it going? How are all the medical conditions? And then we like to turn to the environment and say, well, what's changed in the environment? Well, we all know, dealing with COVID right now, that everything has changed in the home environment. So that's important. We need to worry about overstimulation. All of us have a tendency to want to watch the news. Let's see what's going on in the world. And that can be very upsetting at times. Try to keep that down and or do that in a distanced place from your loved one with dementia, because that could be contributing. Sensory deprivation, right? I'm stuck here in the house. I'm not getting any sunshine or fresh air. I'm not able to go to my normal day program and interact. This is not my normal routine. Where are all my family members? These are issues. And so it's expected right now that there's going to be increased difficulties seen in some of our loved ones with memory and thinking problems. And that is going to produce more challenges for caregiving. Again, we need to be thinking about this. Have they caught COVID? Are they dehydrated? Are they in pain? Are they not sleeping right because we're stuck in the house all day? They don't know what's day or what's night. We also need to think about drug effects. Make sure, we keep those medicine bottles away from them. We're stuck in the house. They're always there. They look like candy to some. We also need to think about intoxication. If they're sitting at home and they're used to having a bourbon every evening, well, do they think it's the evening hours at 10 a.m.? And always remember, somebody with memory and thinking problems never drinks more than one, or at least they can't remember that they've already had one. So they keep moving on and on and on. So really, really important For caregivers out there, one of the ways, if you're having difficulties currently while we're locked in our homes, would be to keep a diary of symptoms. This can be really helpful, especially if you reach out to me or to your other doctors and say, we're having trouble right now. Having a diary of symptoms really can help. So we want to know a few things that you should write down in that diary. What exactly are the symptoms? When are they occurring? Do they occur every morning? Are they occurring every evening? Or are they truly random? And one of the best ways to know that is to actually write down the time. How bothersome are they? That's both to the patient as well as to the caregiver. Are these bothersome, or can we just ignore them? What seems to trigger them? Do they start, getting nervous, upset, anxious every time the doorbell rings? Well, maybe we want to think about that and disconnect the doorbell and have people knock instead. I don't know if that would help or not, but maybe. What seems to help make these problems better? What makes them worse? So we can talk a little bit about how we manage these. And these are just a few quotes. The best management of disturbed behavior is not through containment, not locking somebody in the bedroom, but by responding to their unmet psychological and or physical needs. And the deepest craving of human nature is the need to be appreciated. So let's all of us out there give a big hug to our loved ones with memory and thinking problems the next time we see them. So many environmental factors, we've talked about these already: excessive stimulation, loud, overly stimulating news on the TV, watching movies that have a lot of violence and loud noise in them, that lack of structure in daily routine. So many of our loved ones with memory and thinking problems have previously been in day programs or had a daily structure, and COVID has just thrown that by the wayside. So we shouldn't wake up every day and say, well, I've got all day long, I can just wing it. For our loved ones, putting together a structured routine is incredibly important. Inadequate lighting. Go ahead, turn on the lights in the house. The cost of electricity as well as gasoline is down right now. Spend a little money. Don't keep the house dark and scary. Don't change the furniture around. I know we're stuck in the house. There's a tendency to say, by golly, I've always wanted to see how the living room would look with the couch over here rather than over there, and move that furniture around. That could cause issues for us now. Excessive demands. As a matter of fact, I was on the phone this morning with a young lady. Her husband has Alzheimer's disease, and he keeps going over to the neighbor's house. Their neighbor actually has COVID virus or some other flu-like illness, and he keeps going over to check on her, which is a good thing to do, but he doesn't remember to wear a mask. He doesn't remember that she's sick and he has to take precautions, and she's constantly yelling at him, why are you going over there? Well, he doesn't understand that, and the demand that he should be monitoring his own behavior is just too much for him. The distressing behavior of others. This is a time where all of us are having difficulty at times with our tempers or with depression because we're shut in and distanced from our normal routines. And remember that if we're exhibiting distressing behavior, our loved ones are going to pick up on that. And then, of course, loneliness and boredom. And all of us are experiencing that currently. Find ways to stay active and engaged. If we do end up having difficulties thinking about distracting, redirecting the patient, well, let's not fiddle with that right now. Why don't we go make some cookies in the kitchen? Great way to just diffuse the situation. Adjust the environment, turn up the lights, provide structure, routine, avoid overstimulation, and then again, plan those activities. So, what do we do for the caregivers? Well, number one, we know that training caregivers significantly reduces both caregiver distress and problem behaviors, and that education and training can help ward off depression. So, one of the reasons why we're here today, and for many of our programs over the years, is to try to help support the caregiver. It's not just about the patient or the person with memory and thinking problems. This is a medical condition that is shared. And understanding these issues and changing our environment, the way that we interact, is by far more effective than any of the medications that we have.